future, just so that everybody's clear. First off, we are going to finish this set of notes really quickly. It's easy. It's just diuretics and kidney stones. And then we'll start respiratory system. We'll finish respiratory system on Tuesday, and I think that we should have time. Look at you. We should. I'll trade you that for some fair trade organic chocolate with 0 sugar. I think on Tuesday we should have time to do the respiratory quiz together, but I'll post it over the weekend anyway, right? I think we should have time. If not, it's not going to be due until after class on Tuesday, like Tuesday evening. Does that make sense to you guys? And then just to reiterate things to come, Thursday will be your last test. Tell me what Thursday's test covers. Blood, urinary, respiratory. Yeah? Okay. And then I don't remember, but maybe you guys remember, what is the date for your final and the time? December 13th, which is what, Tuesday or Thursday? Thursday, December 13th at 9:10 to 11:10. Does that sound right to everyone? Okay. No, you don't have any regular classes. And last thing to remind you guys is that my last office hours for the semester will be next Friday. I don't have office hours during finals week. You know it's too late during finals week, don't you? All the talking should have already been done during finals week. So my last office hours for the semester, I have them still this week and next week, right? Regular ones, okay? But then in addition, next Thursday, I have office hours usually 9 to 3 or 10 to 3 or something like that. So like most of the day. So if your work schedule needs for you to plan for that, do that, because that's the last day that you can look over your tests and take notes from your tests. Okay? And about 60% of the final exam questions are off of old tests. So you definitely want to have all those written down if you haven't taken the time to do that this semester. Is that clear? Yeah? Okay. All right. So I feel like I'm forgetting to tell you something, but I don't know what it is. Okay. Diuretics. I think we finished this stuff, didn't we? Temperature? Yeah, okay. So I just want to tell you guys how diuretics work. So theoretically, guys, a diuretic is, of course, something that makes you pee more, yeah, right? So it could work on filtration, right? It could make you filter more. It could work on reabsorption, yeah, it could make you reabsorb less. And in theory, although it's arguable whether any of them do that, it could actually even work on secretion if it, for instance, made you secrete more sodium, for instance, right? So I want to look at these, and I want you to think about filtration, reabsorption, and secretion as we go through each one and see which process it's impacting, okay? So there's 2 categories of diuretics that I know that are used like in clinical situations. One of them, as far as I know, and if you guys know better than me, this one is only used in inpatient situations, and I think this one can be used in either way, but I might be wrong. Okay, so remember that you do sodium and therefore water reabsorption twice, right? You do PCT, sodium and water reabsorption, and that's non-regulated, okay? And then you do DCT, sodium and water reabsorption, and that's regulated by aldosterone for sodium and ADH mostly for water. You with me? Okay. So do you remember the proportions? What percentage is regulated, or what percentage goes on at the PCT non-regulated? 65, okay, and 35, right? All right, so you have 2 different opportunities to like intervene with reabsorption of sodium and water. Okay, so the first one, there are diuretics that inhibit non-regulated reabsorption, which sounds counterintuitive because I just told you it's not regulated, but you can't regulate it, but we came up with some chemicals that do. Okay, you don't have a regulatory mechanism for, but there are some diuretics that inhibit that non-regulated reabsorption, meaning that they could regulate, inhibit up to 65% of your water reabsorption, which is massive, right? These, if for instance you could inhibit reabsorption of 65% of your water, that would be a massive diuretic effect. And these are really, really effective diuretics. But for reasons that I hope will become obvious in just a second, they're also potentially dangerous. So as far as I know, they're only used in inpatient situations. So here's what happens. If you can inhibit the non-regulated reabsorption of sodium and therefore water at the PCT, what happens is you deliver a boatload of sodium to the DCT. Does that make sense? Because you didn't reabsorb very much of it, okay? And since you deliver so much sodium to the DCT, your body goes, that's too damn much sodium in the urine. And it tries its little hardest to reabsorb all of that sodium at the DCT. But when you do that, of course, it would be in the presence of aldosterone, right? When you do that, it's going to cost you potassium and also potentially impact the pH of your blood. Does that make sense? Because aldosterone regulated sodium reabsorption causes potassium or H plus secretion. Yes? Okay. So why the hell use these? Well, you use them because they're so effective as a diuretic, but these cause a dangerous loss of potassium. So Lasix is probably the one that you have in your head. Its long name, its real name is hydrochlorothiazide, and there are others that are in this category. Does this sound familiar to you guys? Okay. So if you were, for instance, on a Lasix drip, inpatient situation, what would they probably also be giving you? Potassium drip. Exactly. Yeah? Does that make sense? So these are super duper effective, but also really risky, and they also have to keep a really good eye on your pH of your blood during this. Does that make sense? Go ahead.
Does that also trigger the tubuloglomerular feedback?
Yeah, but tremember, tubuloglomerular feedback is just paracrine. So it can't really do very much to like compensate for this. Does anybody, you work in a pharmacy, are these drugs ever given in like outpatient? Yeah? They give it at home? Oh, really? But they give it with the potassium? Ah, interesting. Okay, cool. And if you don't take the potassium, you're going to die with these because they cause massive loss of, and primarily for hypertension, is that what? Primarily for hypertension? Okay, so the other category of drugs are not as effective but also not as risky. And so the second category of drugs includes spironolactone. And these diuretics, what they do is they are aldosterone antagonists at the DCT. You guys with me? So what they can do is they can inhibit that 35% reabsorption. Yes? But they're also called potassium-sparing diuretics because they don't cost you any potassium. Does that make sense? Yeah? So they're not as effective, but they're also not as risky. Is that okay with you guys? Okay. So these two, by the way, both of them, do they affect filtration, reabsorption, or secretion? Yeah, they're both reabsorption, right? They both impact sodium and therefore water reabsorption. Now, I acknowledge that the sodium reabsorption that goes on at the DCT does not necessarily mean water reabsorption, but if you don't generate a sodium concentration gradient, you won't have water reabsorption even if ADH is there, right? So does that make sense? So it's manipulating sodium, which will cause water to follow or not follow. Okay, so let's talk about other ones. Other things that aren't necessarily they're not prescription diuretics, but they have diuretic effects, okay? Alcohol is a diuretic because it actually inhibits the release of ADH, right? So it's actually an anti-diuretic, right? And so alcohol actually affects, again, filtration, reabsorption, or secretion. Reabsorption, right? It inhibits water reabsorption at the distal convoluted tubule is what it does. That's why you pee, okay? Now, just so you know, like really chronic alcohol will also bump up your blood pressure, but we're just talking about normal alcohol use. We're not talking about excessive alcohol use, right? Just a couple of glasses of wine. Why does that make you pee? That makes you pee because it inhibits ADH release. Good, okay. And then caffeine is a diuretic. We all know that, right? Caffeine makes you pee. And caffeine makes you pee primarily because it increases your blood pressure. And so what does that one affect? Filtration, reabsorption, or secretion? Filtration, reabsorption, or secretion. Which one's pressure dependent? Filtration, yeah? It increases filtration, so it increases your GFR. Good? Okay. If you want to really, really pee, you drink an Irish coffee, right? Right? You drink a whiskey in your coffee, yeah? With some whipped cream on top. I went to the place in San Francisco where they came up with the Irish coffee, and oh my heavens, that is the most delicious thing I've ever had. Okay, and I don't even like whiskey. Osmotic diuretics, like we talked about last time, So I want to think about this one. An osmotic diuretic would be a substance that you take in, right, that gets pushed out and can't be reabsorbed or can't be reabsorbed completely. Like, for instance, glucose in a diabetic, right? Okay. Or an over-the-counter diuretic, like I told you guys last time, often sold for like premenstrual symptoms and bloating, and like Premarin has that in it, and then Doan's water pill have those in them. A lot of times during a certain portion of a woman's cycle, you'll get like tons and tons of bloating, right? You'll feel like your rings don't fit and you need new pants and your nose is swollen. So, and you're also just pissy as hell. You can't take care of the pissy, but you can certainly make your pants fit a little better with diuretic. So what this diuretic does, mannitol is what it is. It's just something that you take in. It's relatively innocuous and gets pushed out and then just stays in the tube. And as it goes through the tube, it exerts an osmotic effect, right? And so it makes you pee. But I want to go ahead and acknowledge that even though, I mean, I know that you guys know this because you're a smart group of people, but just because something is sold over the counter does not mean that it's not dangerous. Yes? So you can use these inappropriately and you can kill yourself or end up in the hospital. And it's actually not as uncommon as you would think. So a lot of times women, sometimes men too, but it's more common in women, will take these medications. And if it says you can take it for 2 days, right, in a row, and then you need to not take it for a while, or you can take this much milligrams and then not anymore. They will double up, triple up, take it for long periods of time, especially people who are suffering from anorexia or bulimia. They want to get this water loss out. Now, what's the problem there? The problem is several things. Dangerous dropping of blood pressure if you have massive diuretic effect. You can go into shock because of this, yes? Also, potentially depleting ions, right? You can cause hypokalemia, hyponatremia, and hypocalcemia with these. And although it seems counterintuitive, you can actually kill yourself with those. Not with proper use, unless there is something wrong with you metabolically, but with improper use, you totally can. So they're not as innocuous as they initially seem. But you guys know this by now. You can kill yourself with anything if you try hard enough. Can you kill yourself with Tylenol? You sure as hell can. And it's not even that hard. It's not even that hard to kill yourself with acetaminophen. Okay, so last little bit on this set of notes is just to talk about kidney stones. What are they? How do they work? What can we do to prevent them? So they're called renal calculi, and what they are is crystalline mineral structures that actually form, and the primary locations that they form are in your calyces, major or minor, in your pelvis, and then in your ureter. And so what you do about these depends on how big they are and who you are and how much treatment you can stand. A lot of times if they're small, you're just going to have to pass them, which is the time in which you are happy for your short urethra, women, right? We're all really jealous that they have a handle when we're camping, but definitely not when we're talking about kidney stones, because you have to pass this all the way through your ureters. It doesn't usually hurt as it's going through your urinary bladder, but this is what these bastards look like. Put that through a urethra and try to have a good day. I have a couple of these in my office. Students bring me this crap and I just love it. Like, the answer is yes. I've got something weird. I've also got a placenta. I've got these. I've got gallstones. It's amazing. My husband won't let me keep them at home. So what'd you say? What'd you say? Yeah, I don't know. I've not done. Yeah?
My dad has had like countless, and he's a big guy. He's like 6'6", whatever, and he literally can't get off the floor. Like, I have to, like, multiple times I carry him in the car and go to the hospital, and then he does. You go through all the lithotripsy, the pounding when you're getting to break up the stone.
Yeah, so they do like mechanical stuff to try to break them up, and they do like shooting. What's lithotripsy is shooting what kind of waves? Sound waves, right?
Yeah, but they pound on your kidney.
But the problem is that even if you break them up, they still have to come out. Then you just have, instead of a big rock, you got 25 little rocks that are coming out of your penis. Not a good day. Go ahead.
It's what causes them to not pass. Because I think we need stones and I have to look for them every year because they don't pass. They just grow.
it could be something anatomical about your tubes, right? It also could be something about your metabolism that just causes them to grow so quickly. So let's talk about what we know causes them and a couple of things that we know could prevent them. So conditions leading to formation. If you do not take in a lot of fluids, especially a lot of water fluids, that's the fluid we're supposed to be taking in, you will have very concentrated blood, therefore really concentrated urine, right? And lots of potentially crystalline minerals in your urine. Also, if you were taking in that anything that impacts the acidity of your urine, crystals are more likely to form at certain pHs than other pHs. So if you have abnormally acid or alkaline urine caused by a lot of times drinking soda. Soda is trash. We all know it, right? Okay. And I'm not saying that because I'm feeling superior, because I will still drink a soda on occasion. But you should probably consider sodas like you consider a banana split, and eat and drink a soda about as often as you have a banana split. Which, you know, if you're doing that every damn day, you ain't making good choices, right? If you're drinking sodas every damn day, you're not making good choices either. So it impacts your urine. Also, ingestion of excessive mineral salts. This is not easy to do, but if you were taking things that were excessively, like lots and lots of particular ions. And then if your parathyroid glands are overactive, they'll dump too much calcium into your bloodstream, which makes it more likely you're going to form crystals, and also phosphate. And then soda consumption. Now, we put a question mark with soda consumption because we've never figured out what exactly the connection between soda consumption and kidney stone formation is. But we know that they're so strongly correlated that I put a question mark there, but it is a question mark just about mechanism. That it says if you are a soda consumer, you are increasing the likelihood. In addition, you're probably also consuming less water. Yeah? If you're consuming lots of soda, you're consuming less water. You're impacting the pH. Go ahead.
Does soda affect your pH?
Yes. Most sodas are relatively acidic.
Okay.
They're like a little tang. That's part of why we like them. Yeah, they're relatively acidic. They also have a high concentration of sugar in them. And the only thing that's worse than a soda is a diet soda for your kidneys. Diet sodas are even saltier than sodas. That's part of how they make you distracted from the fact that they don't actually have sugar in them. So diet sodas are really, really nasty for your kidneys. They also taste like crap, guys. Let's acknowledge. They just taste like crap. And then let's just ask ourselves a question, just thinking as a group here. I want you to think about the people that you know that drink a decent amount of diet sodas on a regular basis. Are they the thinnest people that you know? No, they are not. Because one of the things that we've figured out, and then we talked about this at the beginning of the semester, is that consuming artificial sugars also makes you want more sugars. And remember that we talked about the fact that insulin causes lipogenesis. It causes you to, right? Artificial sodas actually cause insulin release. So they cause you to actually put on fat. As much as regular sodas? No, right? But more than zero, more than the amount of calories that you would imagine. It's interesting, your body tastes that artificial sugar and says, how about some insulin? And just releases it. So whatever else you are taking in is more likely to be stored as fat, right? So, okay. And I do not feel superior. If I buy sodas, I will drink sodas. So I can't buy them. And if I do buy them or my kids buy them, I have to put them, we have a really, really high shelf that you need a ladder to get to. I put them up there, and then if my husband hears me getting out the ladder, he's like, what are you doing? And I'm like, mind your business. It's the crawl of shame up to the surface at the top. It has to be humiliating and difficult to get the damn things down. Okay, go ahead.
We have one of the facilities I work at, a lot of the residents that have diabetes will drink diet soda. So would that possibly be good because it's releasing insulin?
You do not want your insulin regulated that way.
Well, I know, but like, would that be like kind of negative?
Well, if they're type 1 diabetics, no, you don't need more insulin with type 2 diabetes. I was about to say, if they're type 1 diabetics, they probably can't release insulin anyway. And if they're type 2 diabetics, their whole problem started because they were releasing too damn much insulin. So is it better than drinking regular sodas for a type 2 diabetic? Yes. Is it worse than drinking water? Yes.
Oh,
Yeah, for sure. Okay, so what do you do about them? Drink lots of fluid, specifically water fluid. Okay, that's the one that we're all supposed to be drinking, especially before bedtime, which sounds like a nuisance because you're going to have to pee. But it also means that the stuff that's just sitting in your calyces and your ureter overnight will be more diluted, right? It also means you're going to have to get up and pee in the middle of the night. Sorry about that. And then limit intakes of certain ions, but not others. Don't limit calcium intake, even though calcium is in there, but you can limit some of the things that are bound to calcium, like oxalate, urate. Okay, and then the last little tidbit in here is just to remind you that we talked about dialysis at the beginning of the semester, and we can just reinforce dialysis now because, of course, we know that what should be happening is with a properly functioning kidney, you do filtration to get rid of, for instance, most of your urea, and then you do secretion if necessary to get rid of the rest. But what if your kidneys are failing? Well, then, of course, you're going to have urea in your bloodstream. And so what you do is, of course, you send it into the dialysis machine, and the blood with high urea goes by the dialysate with low urea, and you use diffusion because filtration failed you, right? That's how dialysis works. And there's a text box in there because I know all of you guys read your textbook. Show of hands, how many of you guys actually use your textbook? Okay. Meh. Okay. All right.
Wait, do kidney stones have permanent damage? Do they cause permanent damage?
If they scar the tube, they can cause permanent damage. Probably with his dad, with all of the issues that he's had, his tube is probably scarred on the inside. His ureters.
I know a lot of people have just have one. So is that usually like?
Yeah, you're usually fine with one kind of almost any injury because it is. The lining of the ureter is epithelial tissue. It will regenerate if you do not massively damage it, and then smooth muscle and then connective tissue. So it's probably going to be fine with a single kidney stone. But after you have a whole bunch of these bastards, you know something went down in there, right? Okay? That's obviously scientific. You can tell. Those names are scientific. Okay, so let's start respiratory system. Respiratory system is fine. I guess it's just not my favorite. It's part of the reason I do it last. But you guys will understand it. So let's just remind ourselves of the basic anatomy of the respiratory system. And I'm not trying to insult your intelligence. I'm just trying to level the playing field because some people are really strong in anatomy and some people are not. Okay, so the respiratory system, you guys, of course, know that the objective is to get air to move in, right? Okay, but you need to get air all the way to the microscopic structures called alveoli. But then you don't move air into the bloodstream because that's called an embolism. You move gases in and out of the bloodstream, right? So what we are going to see is the process of the respiratory system includes ventilation. That's breathing. Ventilation has two stages, inspiration and expiration. You guys with me? And then after you've done ventilation, you do respiration, and respiration is gas exchange. Does that make sense? And there are 2/2.5 steps of respiration. So listen to this because it's kind of counterintuitive. External respiration is everything that happens until you get to cellular respiration. External respiration happens twice. Gas exchange from the alveoli to the blood, yes? And then gas exchange from the blood to the tissues, yes? Okay, those are both considered external respiration. And their job is all to serve cellular respiration. Yes? Yeah, cellular respiration is called internal respiration. Okay, so one more time. Ventilation, external respiration, 2 steps at the lungs and at the systemic capillaries. And then internal respiration, which is cellular respiration, just to make sure you get the terminology right. Everybody okay with that? Okay, so what we are going to do is so this is exactly what we just talked about. So conceptually, this is all really driven by gradients. Let's call them concentration gradients for right now. So just think about this. Why does oxygen move from your alveoli into your blood?
Low concentration or high.
Yeah, high here, low there, right? Okay, and then before we get into the details, why does oxygen, we'll just follow oxygen with this story. Why does oxygen move from your systemic capillaries into your tissues? Same reason. Okay, but here's the question for you. What is generating the concentration gradient that pulls all of this oxygen in? What is something that is always using oxygen and always generating carbon dioxide and will never be satisfied until you're dead? Cellular respiration. So the basis of the concentration gradient is always that living tissues are never satisfied with the amount of oxygen they've got, and they never stop generating carbon dioxide, right? So whereas this level of oxygen is relatively constant, this level in the cells is never satisfied, and it drives the whole damn thing. Does that kind of make conceptual sense to you? Okay, so external respiration, ventilation, and then internal respiration, which is cellular respiration. Okay, so now let's talk about how breathing works, how ventilation works. It's actually pretty logical, and it's kind of cool. So with ventilation, basically what you are going to do is you are going to use what we call Boyles Gas Law. Let me find Boyles Gas Law. Okay, and this is an easy physics law. Okay. Boyles Gas Law simply says that if you've got gases in a container, yeah, and let's consider my thoracic cavity a container, okay, and there are gases in it, in my thoracic cavity. Of course, mostly they're in microscopic structures, but we'll get to the microscopic structures in just a second. So there are gases in this container, and if I close the container and squish it, then the pressure goes up, yes? Okay, and if I stretch the same container, then the pressure will go down, right? Does that make sense? Just because the molecules get closer together when you squish them, pressure goes up. The molecules get further apart when you stretch them out. So, of course, this container doesn't have to stay closed because they have the ability to open and close the container. So here's what happens. Air moves like fluids move. Air moves from high pressure to low pressure, right? So stick with me. What I can do in order to cause air to move in is atmospheric pressure is relatively constant. It's around 760 millimeters of mercury on average. So all I have to do to get air to move in is to drop the pressure in here below what the pressure is there, right? Here's how I do it, guys. I contract my diaphragm. Diaphragm relaxed is like this, right? I contract my diaphragm, and I contract my external intercostal muscles, and collectively those will increase the size of the thoracic cavity, right? And therefore decrease the pressure of the thoracic cavity, right? And then air is going to move in because the pressure is low here. Yes? Does that make conceptual sense to you? Okay, it's really just based on some relatively simple physics, right? Okay, so, and you can feel that, by the way. If you inhale, I want you to feel, if you can, how your ribs sort of pull out and up when you inhale, right? They're increasing the size of the thoracic cavity and therefore decreasing the pressure. Okay, so how does the basics of exhalation work? Exhalation, and listen to this because people misunderstand this kind of consistently, and that is that exhalation is primarily just a relaxation process. So all you really need to do in order to exhale is squish this cavity, right, so that the pressure increases above atmospheric pressure. The primary way that you squish when you're doing normal tidal breathing is simply to relax the diaphragm, yeah, okay, relax the external intercostal muscles. So breathe in, breathe out. And you can actually feel it when you breathe out, when you're not trying to force it, that it feels like relaxation and not contraction. Okay, so what that does is squishes the container enough that the pressure in your thoracic cavity goes above the atmospheric pressure and air goes out. Now, can you also do forced expiration? Yeah, you can like blow out a birthday candle. And when you do that, what you do is you contract your internal intercostal muscles to squish the ribs closer together, right? And you also push up on the diaphragm from the bottom by contracting your abdominal muscles, right? So you're just squishing the container a little smaller so the pressure gets higher, right? But that's only during forced expiration. You would do that like when you're talking, because you need to. You can do it during exercise. You can do it during blowing out a candle, but you're not doing it if you're just sitting there doing tidal breathing. For instance, you wouldn't be doing that when you were sleeping, right? You would just be relaxing and contracting and relaxing and contracting the muscles. Okay, so the basics of breathing are use the muscles to change the size of the container, which changes the pressure of the container. Yes? That's what you're doing. Now, there's a little more to it than that, and we'll get to that in just a second. But basically, this really depends on you having the lungs stuck to the container. right? So if the lungs don't stay stuck to the wall of the thoracic cavity, then you pull out the wall of the thoracic cavity and the lungs won't follow. So one of the things that we'll see is that it's really important that between the visceral and the parietal pleura, you stay nice and wet so they stay stuck together like two microscope slides. And then also in that area, you have to keep a vacuum so that air doesn't get in and allow them to collapse. And we'll get to that in just a second. Okay. So this is inspiration and expiration. Which one is primarily related to muscle contraction? Inspiration, yeah, okay. And expiration is primarily related to relaxation, okay? All right, so now let's get into the specifics, the mechanics, right? And it's not hard. This is not, well, there's one thing that's a little tricky, but I don't usually ask you about it. Okay, so the exchange of air, we're not doing gas exchange yet. We're still just getting air in and out. And air moves, again, like fluids do. So don't be at all surprised. Do you remember the equation that we looked at for blood flow was F equals delta P over R, right? In which the delta P is the difference in pressure between 2 points and the R is resistance and F is flow. Please note that when you're looking at airflow, it's pretty damn similar. The only difference is that these two P's are always the same P's. It's always flow equals the difference between atmospheric pressure and alveolar pressure, which is the pressure in the alveoli of your lungs, right? Okay, over resistance. So before we even get into it, you guys predict for me. If atmospheric pressure is higher than alveolar pressure, air is going to move which direction? In. Yes? And if alveolar pressure is higher than atmospheric pressure, then air will move out. Yeah? Okay. So you're manipulating the size of the container and therefore you're manipulating the P's. But really, which of these P's can you manipulate? No, you can't manipulate atmospheric pressure unless you have godlike qualities that I didn't know. And that would be cool. Can we hang out? Okay. You can only manipulate this one. This one's relatively constant. Now, relatively constant, if you go to different places in the world, different elevations, it changes just a little bit, but it ain't going to change right now for you, okay? And then this one we'll talk about in just a second, the things that actually impact resistance. So basically, it's going to be the changes in pressure, and specifically the changes in that alveolar pressure that are responding, that are responsible for ventilation. And so, like we just talked about, Boyles Law, or Boyles Gas Law, says that if you have a closed container full of gas and you squish it, the pressure increases, and you stretch it, the pressure decreases, right? So we have a closed container that we can open, right? Okay. Interactive physiology is really good for respiratory system. And so we already said that the muscles of respiration, meaning the diaphragm and the intercostal muscles, are the ones that are responsible primarily for changing those volumes. So let's just make sure that we have all of the terminology down, and then we'll just look at what happens. So P sub ATM is atmospheric pressure. It's a relatively constant 760 millimeters of mercury. And the 760 millimeters of mercury is just because, of course, this isn't empty. There are a whole bunch of gases out here, right? And each gas adds to the pressure here, right? So, question for you. Based on this, why would you on the moon, when you contracted your diaphragm and your external intercostal muscles, why would nothing move in? Yeah, there's just no atmosphere on the moon, right? So the atmospheric pressure there is around 0, right? So even if you, no atmosphere to speak of, it's not big enough to hold on to an atmosphere, right? So spacesuit breaks on the moon, right? You're out there and the spacesuit breaks on the moon, and you contract your diaphragm and your external intercostal muscles and you try to drop the pressure. What would still happen to all of the air in you? It would get sucked out because you are in almost a vacuum when you're on the moon. Does that make sense to you guys? Okay. So we really depend on this 760 millimeters of mercury, and this is where we evolved, right? And we ain't going to do very well on other planets if the pressure is dramatically different. Not to mention the fact that it also has to have the right gases in the atmosphere, right? The right gases actually compiling the pressure. Does that make sense to you guys? Okay. So, the atmospheric pressure, and this is important, listen to this. All other pressures are always expressed relative to atmospheric pressure, which is the constant. So listen to this. If I say P sub ALV is 0, I really mean it's equal to 760. If I say P sub ALV is -1, I mean it's 759. Yeah? P sub ALV is +1, I mean it's 761, right? They just don't make you keep track of the 760 every single time, because really all you have to do to cause inspiration is drop 1 below 760. All you have to do to cause expiration is pop 1 above. So let me show you what that means. Ready? So this image, especially the top portion of it. So this is showing you what's happening in your alveoli, right? Relative to the 0 of atmospheric pressure, right? So stick with me, okay? If alveolar pressure goes to -1, yeah? That means it's 1 below 760. Then air is going to move in. Does that make sense? Okay? That's inspiration. Between breaths, does it make sense to you that alveolar pressure will be equal to atmospheric pressure in between your breaths? Yeah? Because it's not moving anywhere, right? It's just like by default, if you just sit here and not breathe for a second, pressure in here equalizes with the pressure out there and nothing moves anywhere. Yeah? Okay. And then to cause expiration, all you have to do is pop it 1 above, 1 millimeter of mercury above atmospheric pressure. And you do that again by contraction or relaxation of muscles. Yeah, by relaxation of muscles. Now, would this look any different if I was, for instance, wouldn't it? In order to cause inspiration, I wouldn't just go to, for instance, -1. I might go to -2 or -3, yeah? And in order to cause massive expiration, I just go further above. But it's the same story, right? All you're doing is changing the pressure with reference to atmospheric pressure. Is that okay with you guys? Okay. All right. So that's basically what you're doing. You're changing the size of the container, which changes the pressure of the container relative to atmospheric pressure. So it's pretty like logical physics, isn't it? It's pretty logical physics. Okay, so this one can kind of confuse you, so don't worry about it too much because I don't ever ask you P sub TP. I will ask you P sub IP. So let's just look at this one. Okay, so all of this depends on when I change the size, stick with me, when I change the size of my thoracic cavity, my lungs have to go with it. Otherwise, this wouldn't do anything, right? So I don't just need to increase the size of my thoracic cavity. I have to actually pull my lungs out, right? So that my lungs have lower pressure. Otherwise, the air wouldn't move into my lungs, right? But can we agree that the lungs are not stuck to the wall of the thoracic cavity? Because there is a visceral pleura and a parietal pleura, and then there's fluid in them. So here's what you have to do, guys. What you have to do is you have to get the pressure in the pleural sac right here. It has to be negative and they have to be wet. So you basically have to have a vacuum that sucks out and makes the pressure in the serous fluid about -4 all the time. Okay, so what's going to happen here is if that pressure is negative and the two serous membranes are wet, then they stay stuck to one another by hydrogen bonding. But what if you poke a hole in that? Then the air is going to allow the elasticity of the lungs to just collapse on themselves. That's called a pneumothorax. So let's look at a picture that shows you that. So here's a happy, healthy person, right? Okay. So between breaths, the alveolar pressure is 0. Everybody cool with that? It's not breathing right at this moment. And the pressure right in here, called the intrapleural pressure, the pressure in the pleural sac, in the serous fluid in the pleural sac, in a healthy person is -4. What is the function of that -4? It keeps the two membranes stuck to one another with that negative pressure. You generated the negative pressure during development, and hopefully you've never actually damaged it, yes? Okay, so as long as that is -4 and these are moist, then they stay stuck, and so when you pull out your thoracic cavity, your lungs go with them. Your lungs are nice and stretchy in the wall, too. They like to stretch out in a healthy person, and then they snap back, but they don't let go of the wall to push out the air. But This person is having a bad day. What happened is he got into a car accident, or somebody stabbed him, or somebody shot him. Car accidents, this occurs not uncommon. It's not uncommon in car accidents because your ribs are pokey, right? So what happens in this situation is, let's say a rib or a knife, whatever, punctured the pleural cavity, yeah? And what's going to happen to the pressure in here? It's going to equal atmospheric pressure, right? So it's going to go to 0. And then what's going to happen to the hydrogen bonding that was actually keeping the two serous membranes stuck to one another? It's going to let go. It can't really overcome that, right? Because the lung is elastic. So you've got this little battle between the elasticity of the lungs and the hydrogen bonding that's keeping it stuck. And you're still going to stay stuck, right? As long as there's a negative pressure there. But if you allow air in there, then the elasticity will just collapse the lung. And so this was something that I don't know why. It was super interesting to me when I learned it. This is a collapsed lung, but do you actually have to touch the lung to collapse the lung? No, you don't have to touch the lung at all. All you have to do is let air into the pleural cavity, and then the lung will collapse because of its own elasticity. But the good thing, there is a good thing on a day like this, is that the other lung is in a separate sac. Yeah? So hopefully that one still got negative pressure and is still functioning and will keep you alive until you can reinflate this one. And I bet you guys have more experience with this than I do. What do they do about the situation like this? What do they do?
Chest tubes?
Yeah, what does the chest tube do?
Suction?
Yeah. So they create a vacuum again. Stick in a chest tube. Suck it out. Depend on the elasticity of the lungs and the moisture in the serous fluid, right? Adheres the lungs to the wall. So you stick in a chest tube, you suck the air out, the thing adheres back to the wall, and then you plug the hole and watch it to make sure it stays inflated, right? Pretty cool, right?
The same thing happens instead of air, it's liquid.
Instead of air, it's liquid?
Yeah, when the pleural cavity,
Uh-huh.
instead of air, it has a liquid. That's what they do. Put tubes and take the liquid out.
They're not really worrying about the liquid. They're actually trying to take the air out. The liquid, some of the liquid will come out because if you generate suction, it will, right? But it's still got to be moisture. This is not full of fluid most of the time. I mean, I guess it could have happened with a person that drowned, right? You can get a pneumothorax and drown at the same time, and then it would be full of fluid. But most of the time, this is just full of air with moisture on the sides. So does that make sense? So the air actually just collapses it because of the elasticity of the lungs. Okay, so they just suck the air right out. Now, we'll talk about this in a minute, but this also can happen to premature or newborn babies, right? None of you are surprised that the respiratory system is the last system to develop, right? Because you're not using it until the very end. So if, for instance, the baby's lungs are not fully developed, and this happened to my son, so my son had a collapsed lung, but it happened instead of out here, it happened in the mediastinum. So this is called a pneumothorax when it occurs from the middle and not from damage from the outside. It's called a mediastinothorax, and then one of his lungs collapsed. He was premature, and it's not at all uncommon in premature babies. And I'll explain to you how it happened and how they fixed it, so it'll sort of reinforce this. Okay, so basically what we need that intrapleural pressure, the pressure in here, to be negative, meaning a vacuum, right? Negative pressure is a vacuum, okay? And in a healthy person, that is the case. And then in addition, and this one I don't usually ask you about in part because I just can't figure out how to make it make sense when I explain it. So I'm going to tell you, at least you would have heard it once. This one that we just talked about was this pressure needs to be low in order for the lungs to follow, right? What the thoracic cavity is doing. This one says that what's happening around here, the difference between the alveolar pressure and the intrapleural pressure is called the transpulmonary pressure. So it's the same kind of concept. It simply means that you need to have a difference between the alveolar pressure and the intrapleural pressure. That's the transpulmonary pressure. And what really needs to happen is the intrapleural pressure needs to be lower than the alveolar pressure in order for it to stretchy. So this says that as long as there is a difference in the right direction, when you pull on them, they will stretch. Okay, that's what the whole idea of transpulmonary pressure is. So So we talked about pneumothorax, and then let's just talk about resistance, and then we'll come back to respiratory distress syndrome of the newborn. Okay, so we've basically learned that you manipulate this one, yes? Okay, you manipulate that one. You can't really do anything about that one. And you manipulate this one by doing what again? I know you've heard it. Say it again. How do you manipulate this pressure? Yeah, muscle contraction and relaxation, right? That's what you do, okay? But this is what we need to talk about right now. The other thing that can impact flow is resistance. And before we even get into it, can you guys brainstorm for me and tell me anything that you think might impact resistance to air coming in and going out, okay? Anything. What?
An obstruction.
Yeah, obstruction. What? Asthma, that's constriction, yeah? Pneumonia. Bronchodilation would decrease resistance and therefore increase flow. What about mucus accumulation? Yeah? Okay. What if there was something that made it not very stretchy so that you couldn't actually expand them very much? Wouldn't that add to resistance too? Right? Okay. So not surprisingly, the vast majority of resistance really occurs in the tubes, right? Just like it did with blood, right? So let's just look at some factors that are related to resistance. So the movement of air into the lungs is opposed by resistance, and resistance is affected by a couple of things. First off, if you have anything that damages or scars the elasticity of your lungs, then they're going to be more resistant to stretching and more resistant to snapping back. Okay, we'll talk about emphysema's function in that in just a second. So what they really need to do is they need to be able to pull out really well and then snap back really well, and pull out really well and snap back really well, okay? So scar tissue is not as stretchy as regular healthy tissue. So if you have scar tissue accumulation in your lungs, like for instance, cystic fibrosis can do that. Okay, and then the next one is the things that you guys were talking about. Anything that impacts the size of the ventilation passageways impacts resistance, right? Okay, so bronchodilation, yeah, or bronchoconstriction would impact resistance, one of them in a negative and one of them in a positive way. So in most situations, in normal healthy situations, bronchodilation and constriction are controlled by the autonomic nervous system. And we've learned this before, but remember, sympathetic nervous system will tend to cause bronchodilation, and then the parasympathetic nervous system causes them to constrict back to normal, right? So that's consistent with the stuff that we've learned. But there are other things that can cause bronchodilation and bronchoconstriction, and that is, one of them is histamine that is released either because of infection or really commonly because of allergic reactions. Histamine is a paracrine agent. Does anybody remember what kind of white blood cell secretes histamine? Mast cells and, yeah, you got it, basophils. Basophils are famous for releasing histamine. So mast cells and basophils release histamine. Even if there wasn't a pathogen, they act as if there was, right? And then they do constriction of the bronchioles, okay? Epi, whether it's hormonal epi or clinical epi, causes bronchial dilation, which is why it's a treatment for instance, allergic reaction, allergic respiratory reaction, and it can be used for asthma as well. And then mucus accumulation, like as you get some kind of respiratory irritation or infection, just mucus gunking up the walls is going to narrow the lumen, right? So you get less airflow. And you guys have all had that, and you'll probably have it once more this winter, mucus accumulation. And then this one's really interesting, and it'll bring us to our next concept that we're going to talk about. So the alveoli on the inner surface, guys, let's find our alveoli picture. Where are you, alveoli? Okay. On the inner surface of your alveoli, this is the inner surface of one of these guys. They're moist. And, you know, most of our body surfaces are moist, right? And the moisture is great because it helps with gas exchange. Moist surfaces do better gas exchange. But it's also a potential negative because moist surfaces also resist stretching because of hydrogen bonding, right? So we've got some, does that make sense to you? Remember, hydrogen bonding makes water want to stick to other water molecules. So it's good for gas exchange, but it's bad when you're trying to get them maximally stretched because they'll kind of oppose that. So if these can't break up the hydrogen bonding, it's going to add to resistance. So the surface tension in the moist alveoli. Luckily, healthy people have a mechanism to temporarily break up the hydrogen bonding if you really want to take a big breath like that, then you're fine as long as you're healthy. That is not true with a premature baby, and we'll talk about that. Okay, so let's talk about some clinical connections. So anything, like we said before, anything that scars your lung tissue can make them less compliant and less stretchy, right? So we do not want to scar our lung tissue because then they won't stretch as well and they won't snap back as well. And then this one is the one that I want to talk about. So the surface tension at the wet inner surfaces of your alveoli, as we were talking about, is totally cool for you because if your lungs are fully developed and you're otherwise healthy, here's what happens. When I stretch these alveoli, I activate this cell, which is called a type 2 cell, which is in the inner walls of your alveoli. And the type 2 cells release something called surfactant, which has a detergent effect, temporarily breaks up hydrogen bonding, right? And so makes it so that you can stretch them, right? So when do these release it? Well, when you're breathing really heavily, right? So if you're exercising, your type 2 cells are going to get yanked and they're going to dump surfactant into the alveoli so that you can temporarily break up the hydrogen bonding. And so you can breathe deeply when you need to breathe deeply. You can stretch your alveoli when you need to stretch your alveoli. However, that is not true for especially a premature baby, and sometimes even full-term babies have this problem. So it is called respiratory distress syndrome of the newborn. And here's what happens. When babies are born prematurely especially, and so my son was only born 2.5 weeks early, but he ended up with this issue. And he had a compounding factor because, and I just talk about this and feel guilty immediately, but because I can't do vaginal delivery because I have a heart problem. So he was born early and he had to be delivered by cesarean section. But vaginal delivery is better for their lungs because as they're going through the vaginal delivery, it squishes all the fluid out, or most of the fluid out. So he's got a double win. He's got extra fluid in his lungs and they're not as well developed. Does that make sense to you guys? Okay. So I know people like to argue about the proper way to give birth, but I'm going to go ahead and tell you that cesarean sections, while generally safe, also have some risks associated with them that vaginal deliveries don't. I didn't really have a choice in the matter, but I still freaking feel guilty. I'm buying a car or something. So here's what happened. He's born 2.5 weeks early, and he's got fluid in his lungs because of the delivery method. And what happens is, has anybody work with babies? Mike Fonseca from the other class, so like he works in a labor and delivery. So he came out, right, and he pinks up. He's looking relatively good, and he cries. So things are looking really good. But then we're watching his thoracic cavity, and what you see is, in these little teeny babies, they are straining really, really hard to inspire, right? But then expiration is passive and elastic, so their little thorax just sort of collapses down on itself. And then they strain really hard to inspire, and their thorax just collapses down on itself. So all of that straining with his like poorly developed lung tissue popped a mediastinothorax, and one of his lungs collapsed, right? But luckily, I was in a fantastic hospital. It was a high-risk pregnancy anyway. I was at St. Mark's. They knew that there were some potentials for problems and that he was coming early, and he had fantastic care. So what they did, of course, with him is first, chest tube, sucked it back out, sucked his lung back out, right? Actually, they did it this way. They didn't even poke a hole because he didn't have an outside hole. They sucked his lung back out, made sure that it stayed inflated. And then we, not me, but brilliant people, have made surfactant in the laboratory. And they can deliver respiratory surfactant to babies who are premature and having trouble until they start making their own, which is usually just a couple of days after they're born, unless they're super premature, and then you might have to deliver it a long time. So they delivered respiratory surfactant so that his breathing was no longer as labored, and then allowed for this to heal. And of course, he was in a little plastic box for a few days, and I couldn't touch him. But then he healed, right? He was fine. And then he stayed there for long enough that they made sure that his lungs were fully developed and his O2 saturation went almost up to 100. And then they sent us home. And you guys paid for that. Thanks, guys. And we were about an $80,000 births, my son and I, with between my heart problems and his problems. But he is also one of the best humans that's ever existed on this planet, and he's going to fix all the crap that people made. So you should be happy. He's worth it. Okay.
You say 8 or 8?
What?
You say 8,000 or 80?
$80,000.
Average birth is 7,000.
What?
Average birth.
Yeah. Well, I was in the hospital for, we were both in the hospital for 10 days. And he was in the NICU for 10 days. Those nurses are fantastic humans. I've never been more impressed with medical professionals than I was with NICU nurses. Not only are they kind, but they are smart as hell. And they work their little butts off. So yeah, we were both in the hospital. But anyway, I learned a lot through the process. I also learned that I do not want another child under any circumstances. You can have all my junk if you want it. Take this uterus. So it's done. We're done with that. Like, everybody almost died. That was super stressful. Okay. And you guys everybody got mad at me because I kept saying that with a pregnant. Oh, by the way, she had her baby, the girl who's in the other classes. She had her baby. It's a little girl. She's beautiful. She sent me an email saying, "We didn't die." I was like, thanks. I'm so glad. I had to apologize to her and hug her later. I'm like, "I'm really sorry." And she's like, "It's fine. I know you. I love you." I'm like, "I'm sorry. You're going to be fine." She's like, "I know." Like, I wasn't trying to scare the hell out of you. Okay, so anyway, that's respiratory distress syndrome of the newborn. Far more common in preemies, but can happen in full-term babies. This is one of the reasons why, just editorial comment, even if you are going to do a super natural birth, like you're going to give birth in a tub with a midwife and candles, make sure that you have a plan B that can get you and your baby very, very quickly to a hospital, right? Make sure that you prepare for the eventualities that you might not realize can happen, and everybody can get medical care quickly if necessary. Because respiratory distress syndrome of the newborn can happen in full-term babies too. Okay, so last little clinical connections on here is just, have you ever heard I think I've used the term COPD with you guys before, chronic obstructive pulmonary disease. Since it's obstructive, does it make sense to you that what it's really doing is this, affecting resistance? Yeah, obstructions, okay. It's not so much affecting the pressures, it's affecting the resistance. And it's really an umbrella term, by the way. COPD is like an umbrella term of like almost anything that causes like obstruction in the flow. So what kinds of things could be involved with COPD or lead to COPD, right? You won't necessarily be diagnosed with COPD just because you've got bronchitis, but it can definitely lead to that. So COPD can be associated with chronic bronchitis. So if you have bronchitis over and over again, just because you've got a respiratory predisposition, a lot of times people with asthma have a predisposition to chronic bronchitis. And what happens is like your respiratory tract gets irritated, mucus clogs the airways. If it happens over and over again, causes inflammatory responses and can also cause fibrosis, which is scar tissue formation with chronic bronchitis. And then emphysema. Emphysema is a really interesting one. Emphysema is when you have chronic respiratory irritation. A really good way to get emphysema is to smoke, yeah? And most people who have emphysema were smokers or are smokers, but not everybody. You can also work in a coal mine. Yeah, that'll do it. There was also a really famous case, which was kind of funny, of a woman, I mean, it's not funny, but I don't know what it is. Not ha-ha funny, peculiar funny. Of a woman who got emphysema. She had never smoked a day in her life, but she worked in a Swiss Miss cocoa factory. You know what happens when you open those things? Nothing about working in it, right? She's like breathing it in, and it's irritating her lungs, and she ended up winning that lawsuit. She's like, "I like got it from here," and they're like, and she's like, "I totally got it from here," and then eventually they're like, "Yeah, you got it from there." Okay, so what happens is with chronic irritation, your alveolar walls will start to lose their elasticity. This basement membrane here is relatively elastic in between. And so what happens is they don't stretch very well, but they also don't snap back very well, right? So what happens is you're left with that residual volume in your lungs, and you're not doing very good gas exchange because you can't stretch or snap back. And so, of course, you're going to strain, getting a lot of air. And then in the later stages of emphysema, what happens is your alveoli, if this was your little grape cluster of an alveolus, obviously drawn really well, you go from having little grape clusters that have a lot of surface area to having plums, which don't have very much surface area. So they break down. So let me show you a healthy lung versus a lung with emphysema. Okay, so you guys have probably seen this before, but if you haven't, healthy lungs are really, really dense. They have lots and lots of surface area. This is made of millions and millions of microscopic alveoli. So if you touch a healthy lung, it's really dense tissue. I thought until I was too damn old that the damn thing was a garbage bag and it just filled up and emptied, because sometimes I am dumb. And I blame it on my Texas education, honestly. They just barely started teaching that slavery was involved in the Civil War. Actually, it's in the books next year. Texas, next year.
What?
Seriously.
What did they tell them it was about?
They told him it was about states' rights. No, seriously, that's how I was educated. In addition, all of Texas does not require sex education at all in any of the public schools. None of it.
Well, the North
Right.
learned about how the South continues to teach that.
Oh yeah. I'm just revealing my former ignorance. I did do some education, some deep level education since then, but a lot of things to take care of. And I was actually relatively surprised, A, that the Holocaust was as big a deal as it was because of how I was educated, and B, that slavery was the major thing. And I had some really, really humbling moments during college classes in which I opened my mouth, and then I realized, I don't think you know things, Melanie. You should probably be quiet. So, but you've probably got some too. Yeah? Everyone has their sort of cultural bias, and it's nice and also terrifying when it's revealed to you. Like, oh my God. What? Yeah. Okay, so anyway, that was one of my dummies. There's a whole bunch of them. I keep finding them now. I'm like, I don't know why anybody ever talks to me. I'm an idiot. Okay, so really, really dense. This is healthy lung tissue. But with emphysema, this is a postmortem photo of lung tissue with emphysema. Do you see how much surface area you've actually lost there? I don't know if we still have it. Do you remember, Sarah, if we still have the cadaver with lungs with emphysema? So when you touch a lung that is healthy, it really bounces back and it's got lots and lots of density. When you touch a lung with emphysema, your finger just keeps going in because it's all just a bunch of big bubbles, right? It's pretty freaking fascinating. I don't know if we still have the lung with emphysema. I should have kept it. So anyway, that's an emphysema lung. That one's really interesting. So gas exchange gets really inefficient and you're going to really, really strain about breathing. COPD is often due to long-term irritation. Cigarettes, of course, is a really good way to get it, but I have terrible news for all of us.
We're all gonna get it.
Air pollution is also super terrible, a super easy way to get it. And the reason that this is, I know I'm just a ray of sunshine as a general rule, but this is one moment which was kind of shocking to me. So I take all my lab aids, and I'm going to take you guys in January if you want to go visit the body donor program. And the body donor program is also where they do all the cadaver dissections for the med school. So they've seen tons and tons and tons and tons and tons of cadavers. And one of my students was with me, and she asked Carrie, who's the director and also the dissector for the program, she said, can you tell me the difference between a smoker's lung and a healthy person's lung? And he's like, well, yeah, smokers' lungs are really dark, and there's a lot of evidence that they've been exposed to respiratory irritants and respiratory, not necessarily pathogens, but respiratory toxins and stuff. And he said, but I have to tell you that smokers' lungs are also indistinguishable from the lungs of people who are raised in this valley. So, we have massive amounts of pollution that are impacting our lungs. And they think it's taking around 2 years off of our lives. And it is something that we can do something about, right? We can. It's possible. You just have to make it one of the priorities. I mean, it's really nice to have lots of money, but not if you're dead. Right? You ain't going to do a damn thing with it when you're dead. So asthma, lung cancer, pneumonia, and then we'll get into the whole concept of respiration. So asthma is when the smooth muscles in the bronchioles constrict. Whatever the trigger for asthma is, it's different for different people. It can be triggered by allergens. It can be triggered by exercise. It can be triggered by stress. It can be triggered by a bunch of different things. But regardless, it constricts and increases the resistance so much that the flow goes down, and so you're wheezing and gasping for breath, right? And that's what asthma, you've seen it before, right? And then sometimes asthma, of course, makes your lungs more likely to have chronic mucus accumulation and can lead to bronchitis, and people with asthma or have a predisposition for all of the respiratory disorders that people without don't necessarily. The chronic inflammation can also be destructive and reduce elasticity. Asthma can lead to COPD. It's not like asthma is COPD or always leads to COPD, but it can. So what do they do for asthma? You know what they do for asthma. A combination of bronchodilators and anti-inflammatory medication. And if you can do anything to reduce your exposure to whatever triggers your asthma attack, you can do that as well. Lung cancer. The reason lung cancer causes problems with respiration is simply because if I have a tumor here, I have lost surface area for gas exchange, because tumors are solid masses. Does that make sense? That's not necessarily what's going to kill somebody with lung cancer, but of course it does affect your respiratory function because you lost functional tissue and replaced it with like a tumor tissue. And lung cancer accounts for 1/3 of all cancer deaths, but only 90% of people with lung cancer are smokers. But it's still 90%. Wouldn't you be pissed off if you got lung cancer and you ever smoked a day in your life? Right? It's just because cancer's a dick and it'll just do whatever the hell it wants. But a lot of these, by the way, also are exposed to, like coal miners are more likely to get lung cancer and that kind of stuff. And then pneumonia. Pneumonia is an interesting one. It's an inflammatory condition, and usually pneumonia isn't actually like the pathogen. The pathogen causes respiratory problems, which can lead to pneumonia. And some pathogens are really, really likely to lead to pneumonia. But what happens with pneumonia is really just that you start to build up fluid, and eventually the fluid gets into the inner layer of your alveoli, but not just normal amounts of fluid, abnormally high amounts of fluid, which causes problem with gas exchange. And you literally feel like you're drowning. Has anybody ever had pneumonia but me? It's terrifying. Like, it is really terrifying. You feel the air going in, but it's not doing anything, and you really feel like you're drowning. So that's what pneumonia is.
So it's just on the endothelial cells.
Yeah, it's building up on the inner wall of your alveoli. Too much fluid decreases gas exchange. Yeah. Okay, so now what we're going to get to is we are going to talk about the concept of respiration. And I'm going to show you guys a video to start, but I want to define something for you really quickly. Okay, so because we are dealing with gases, and we are dealing with gases in air, yeah? What we have to acknowledge is that gases in air, or gases not necessarily also in fluids, they move down concentration gradients, but they also are dependent on pressure. So like if you squish it, it moves differently, right? Okay. And then also if you heated it up or cooled it down, it would move differently. So for that reason, physicists, and I am definitely not a physicist because there's way too damn much math and physics. I was like, I'm going to take 2 of these and then I'm done. Okay, so physicists say that oxygen does not move due to its concentration gradient. Oxygen moves due to what we call its partial pressure gradient. So let me just spell this out for you, and then it's going to be pretty much the same. It's going to be analogous. All right, so here's the deal. All of the gases in the atmosphere generate or account for the 760 millimeters of mercury. The primary gases that are in our atmosphere are oxygen, carbon dioxide, nitrogen, and water. And then there's a bunch of others, right? There's a bunch of other stuff out there too, okay? So we call that basically atmospheric pressure. But what each of these contributes to the atmospheric pressure is called its partial pressure. So instead of saying oxygen moves down its concentration gradient, they say oxygen moves down its partial pressure gradient, from its high partial pressure to its low partial pressure. And the only reason that matters is because if I squished you, I could make the gases move differently. Or if I heated you up, I could make the gases move differently. But I'm not going to squish you or heat you up, and you wouldn't agree to it anyway, would you? Okay? So for our purposes, saying that oxygen moves down its partial pressure gradient is analogous to saying that oxygen moves down its concentration gradient. But you're not going to run into, once you talk about the respiratory system, they're always going to use PO2 and not the concentration of oxygen. So it's a partial pressure gradient. But other than that, it's pretty much the same thing. So the movement of gas molecules basically is due to the amount that is in the gas, the amount that is in the gas, and they move down its a partial pressure gradient. So, and the other important thing is that gases move due to their partial pressure gradient. So oxygen moves from high oxygen to low oxygen. Carbon dioxide moves from high carbon dioxide to low carbon dioxide. And the other gases in the mixture do not directly impact what one gas is doing. So oxygen cares about oxygen. Carbon dioxide cares about carbon dioxide. So the only reason I'm explaining that is because you will see this term used and not that term used. Okay? All right, so gases move down to their own partial pressure. So what I'm going to do is I'm going to start with an animation, right? And then we'll sort of fill in the details and make sure you learn all of the terminology. So I'm going to show you guys an animation that shows how gases move. So here's the deal. With this animation, they are going to be using the terms PO2 and PCO2, the partial pressure for oxygen and the partial pressure for carbon dioxide. Okay? And do you guys already know what is the transport mechanism that oxygen uses to move into the alveoli? Just diffusion, right? Yeah? And carbon dioxide uses diffusion. So you don't need to do anything fancy. If you get high here and low here, it's going to move, right? Okay, so when we're watching this animation, I don't want you to concentrate on the numbers, but I do want you to look at the gradients. Look at where it's high to where it's low to predict what's going to do, right? The other one where it's low to where it's high. And then pay a close attention to whether cellular respiration is ever satisfied in this story, okay? All right.
Fresh air entering the lung carries oxygen with a PO2 of 160. The presence of moisture in the lung results in reduction of the PO2 to 104.
That just means that some of it is actually taken up by the fluid. It's not a big deal. Still high.
Fresh air entering the lung carries carbon dioxide with a PCO2 of 0.3.
Low.
The carbon dioxide delivered to the lung from the blood raises the PCO2 to 40.
Still low, okay? It's compared to what we're about to look at.
At the arterial ends of the pulmonary capillaries, oxygen diffuses from the air in the alveoli into the blood, and carbon dioxide diffuses from the blood into the alveoli because of differences in partial pressures. As a result of diffusion, at the venous ends of the pulmonary capillaries, the PO2 in the blood is equal to the PO2 in the alveoli, and the PCO2 in the blood is equal to the PCO2 in the alveoli. With no differences in partial pressure, there is no more net movement of oxygen or carbon dioxide.
So all that happened is you had a partial pressure gradient for oxygen, right? And it diffused until you balanced it out. And you had a partial pressure gradient for carbon dioxide, and it diffused until you balanced it out, right? Okay. And so now, of course, what you're going to do is you're going to pump it to the tissues, and you guys can predict what's going to happen.
Oxygen diffuses out of the arterial ends of tissue capillaries into the tissue fluid, then into the cells, and carbon dioxide diffuses out of the cells into the tissue fluid, then into the blood because of differences in partial pressures.
Okay, so look at the gradient for oxygen, high, medium, low, yeah? And look at the gradient for carbon dioxide, not as dramatic, but still high, lower, lowest, yeah?
At the venous ends of tissue capillaries, the PO2 in the blood is equal to the PO2 in the tissue fluid, and the PCO2 in the blood is equal to the PCO2 in the tissue fluid, resulting in no more net movement of oxygen or carbon dioxide. The blood now carries the oxygen and carbon dioxide to the lungs.
So please note that even though you can balance out by diffusion the concentration of the blood with the interstitial fluid, is the cell ever satisfied? No. So remember way back when we learned cellular respiration, I told you that the relevance of this, even though everybody's tried to make you learn it 5 times, is that cellular respiration is literally the entire reason you have a respiratory system and a cardiovascular system. And it is, right? Because this is never satisfied, right? Cardiovascular system is not exclusively, but primarily responsible for carrying the stuff. And then the respiratory system is primarily responsible for getting it from the atmosphere and returning it.
In the body, all of these exchanges occur simultaneously.
Everybody good? Questions? Okay, so what we will do next is we were just going to look at the details of external and external respiration. And then the last things that we have to talk about in this set of notes is just how hemoglobin is involved in the process, right? And then how the lungs will regulate pH, and then how you control your breathing rate. So I think, like I said, that we will be able to do your respiratory quiz in class on Tuesday, but I'm going to go ahead and post it. You can start working on it, and then we can just correct any errors if we have time on Tuesday, because I think we'll be able to finish. Okay, have a good weekend. I'll see you Tuesday.